When we talk about HIV, we did talk about HIV in basic concepts, but just to reiterate the fact, it can cross the placental barrier, or it could be that the infant is exposed to it during the birthing process. So, what we see is most oftentimes these women are going to deliver via C section just to decrease the incidence of transmission to the fetus during the birthing process. Because the infant will have the presence of the maternal IgG antibodies, diagnosing HIV can be complicated. So, when you think about HIV, if you have a mom that is HIV positive, you should always assume then that that fetus is going to be positive until they are proven negative. So, what you will see is continued testing throughout the first year of life and treatment with the heart medications to suppress the virus. So, those reverse transcriptase inhibitors, the fusion inhibitors, and those such medications. The infant should still continue to receive those normal routine immunizations. And when they are looking for diagnosis of HIV, they will continue to test through the first year of life, and then they will also do follow-up testing if the baby should remain HIV positive or negative, just to continue with that additional diagnosing factors. When we talk about rubella is the most severe infection that we see the most severe congenital anomalies associated with, especially if mom has exposure during that first trimester. So when mom is being tested prenatally, we know that she is going to be tested for rubella. And if she is rubella non-immune, we're going to ensure that she is vaccinated prior to discharge. But what we see with rubella is there's really no specific treatment. It's going to be supportive management. If once mom is vaccinated, we do need to provide simple education to not become pregnant within 3 to 6 months after receiving the injection. So what we see in that infant then is hearing loss, congenital cataracts, cardiac defects, delayed growth and development due to microcephaly, growth hormone deficiency. So truly, there is a great number of effects on that fetus. I would say, however, that you probably should remember that hearing loss is going to be that number one that we will be looking for. With cytomegalovirus, it's an infection that can cause mom to have a miscarriage or also stillbirth or congenital defects. The signs and symptoms of cytomegalovirus are listed out here for you. Diagnosis is going to be elevated levels of IgM in that cord blood. So treatment is going to be cytoven, and what we see is that it all goes back to primary prevention and getting mom treated and diagnosed prior to delivery. With the herpes simplex virus, again, this can be transmitted placentally. We can see direct contact. We can see indirect contact as far as ascending infection during labor and delivery. We can see it transmitted from an infected person. So when we're seeing this, it can cause sepsis-like signs and symptoms, which would eventually end up in CNS complications, DIC, and then death. So what we see often initially is skin or oral cavity lesions, and then it can lead into bloodborne seeding of the brain and lethargy, poor feeding, irritability, those types of things. So if mom is herpes positive, we want to make sure that we deliver her via C-section, not vaginally if she has open or if she has these open sores. And then treatment is going to be with acyclovir or Zovirax, and it's going to be just supportive measures for that fetus or newborn. Group B strep is pretty common, and it is the leading cause of neonatal morbidity and mortality in the United States. We do see a decreased incidence since we do use prenatal testing and give antenatal prophylactic antibiotics during labor. Oftentimes, if we have a mom that's group B strep positive and she has not received those antibiotics, we watch that babe pretty closely. And it can be an early or late onset, so it's kind of a bum deal if our mom doesn't get that ampicillin or Cleocin, Gent, whatever we're going to give her during labor and delivery. So the early onset's going to be within 24 hours, and then that later is anywhere from a week to 3 months. So when we're looking at that, we do want to make sure we get mom treated, or we sometimes we'll see those babies, especially with the early onset, we'll see them getting treated in NICUs for 7 to 10 days of IV antibiotics. If we discharge this mom, we do need to make sure we reiterate the importance of the signs and symptoms of infection and when she needs to call on that newborn. Escherichia coli, or E. coli, is really responsible for a lot of neonatal sepsis and neonatal meningitis. So what occurs is that the baby is exposed to it from the mom's rectum during the birthing process. They're pretty non-specific signs and symptoms, but treatment is going to be with that ampicillin or a cephalosporin. And it can be anywhere from 1 to 14 days, or if it leads into meningitis, then we're going to, treat for up to 21 days. When you are thinking about E. coli, think about the lady that has prolonged rupture of membranes, so 18, 24 hours, those types of things. And so that bag of water is not intact anymore to protect the baby. So it's going to be really common and very easy for transmission to occur in those types of instances. So that's why we really encourage, or our providers push for those moms to be delivered within 24 hours of rupture of membranes. Staph A is, it comes from our hands. And so all I can really say about it is that you need to go back to 101 and remember good hand washing and hand hygiene. So signs and symptoms, conjunctivitis, or they might have some vesicles or pustules that can form into bullae. So the treatment is going to be with some penicillins. We do need to think about MRSA concerns, especially as MRSA has become so prominent in the United States. So be watching and just be very cognizant of washing your hands between each infant. Chlamydia trichomonas can cause neonatal conjunctivitis. It can lead into pneumonia. Really, erythromycin for 14 days is the treatment of choice. And if you recall, during labor and delivery, all babies have that erythromycin and eye ointment within the first hour after delivery. So we will continue to use erythromycin and treat that way. Can also treat with some oral azithromycin if pneumonia would develop. So again, it's educating the mom to be tested for chlamydia prior to delivery. And then it is also important that if she would test positive, that we get her treatment started right away so we don't have transmission via the birthing canal. Oral thrush candidiasis is a fungal infection, and I am sure that we've talked about this multiple times, so I don't really have a lot to say about it. The thing is, again, with your hands, if your hands are dirty, don't go put them in the baby's mouth. We want to teach mom good breast care if she's breastfeeding, how to cleanse bottles if she is bottle feeding. It could also be a culprit of diaper dermatitis, so a nystatin to the diaper area, or the nystatin swish that we, swish and swallow that we would utilize for oral thrush. Typically, it's going to just be white plaques on the oral mucosa, the gums, the tongue, and they don't go away. So mom or dad or whomever, you can't scratch them off. You can't get rid of them. So we're going to need to take them to the physician and then get some nystatin ordered. As far as anti-infective agents, these are all reasons why you would be seeing the use of ampicillin and gentamicin in the newborn nursery. When you're thinking about normal dosages, the normal dose is always calculated off of the newborn's weight in kilograms. And so when you're looking at that, oftentimes your physician will talk with the pharmacy, come up with an agreeable dose, an effective dose, and then you want to make sure that when you're mixing these drugs that you have someone double check you and ensure that you are giving the correct dosages. Ampicillin is not as harsh, but gentamicin is very ototoxic, and we want to make sure that we don't create any adverse effects in our newborns that are receiving them. Things that are going to put our infants at higher risk for infection: I talked about the NICU, and when you look at this baby, you can see it's hooked up to multiple different tubes. So resuscitation, if the baby has needed intubation, mechanical ventilation, those types of things. So prolonged hospitalization, multiple caregivers, especially those that aren't going to wash their hands, numerous visitors, siblings, bottle-fed infants, and then the immunocompromised. So when you're looking at common causative organisms, really when you look at this is several things that we have talked about already. So your septic workup, things you should be looking for and should be cognizant of. A CBC with manual diff, looking at all of the different types of white blood cells. Typically going to be seeing blood cultures done ×2, and they'll come from 2 different sites often. A CRP or C-reactive protein, which talks about inflammation. It tells us how much inflammation is present in that newborn, and the greater the inflammation is, then the longer that infant has kind of been in an infected state. So looking at those C-reactive proteins will be important. Chest x-rays and a comprehensive panel. Lumbar punctures are going to kind of be done a little bit later, but if we aren't seeing anything show up as far as blood work goes, then we're going to want to, continue to move on and keep evaluating and ruling things out. Appropriate treatment then are listed out up here. So fluid and electrolyte maintenance. So an IV mainline, respiratory ventilation support, thermal support, making sure that we're always keeping these babies in a normal thermic environment, and then treatment with IV antibiotics. To talk a little bit about birth trauma. Birth trauma is the result on the neonate during the labor and delivery process. So when you're thinking about birth trauma, things that you should think about are your prima gravidas, so first-time mamas. If you have noticed that when you are working through the labor process that she's had a dysfunctional labor, meaning her cervix hasn't dilated appropriately, or you haven't had good uterine contractions, if we use forceps or vacuums, so anything extraordinary or above and beyond the normal labor and delivery. You can also see these associated with post dates, and post dates create usually create larger babies, so large for gestational age, or babies born of diabetic moms, so that macrosomia. Cephalopelvic disproportion, so if mom's pelvis is not the normal gynecoid shape, or if she has a really big baby trying to be delivered in a smaller pelvis, we can oftentimes see birth traumas happening from those. So really early observation is going to be important on our part. So watching that contraction pattern and paying attention to how she is laboring and dilating. When they're using the forceps or they're using the vacuum, making sure that our physicians are using them properly, and then prompt reporting to our physicians, especially if you're noticing that you have late decelerations or multiple variables, things like that, so that we can be ready prepared for them. So we talked about some of those soft tissue injuries, such as the molding and the caput and things like that. Also erythema, redness, ecchymosis, or petechiae, so bruising. Sometimes abrasions or lacerations. We see the abrasions and lacerations oftentimes accompanying vacuum-assisted delivery or forceps-assisted delivery. So all of those soft tissue injuries, we're really not going to, there's not a lot of med management. I would say comfort is going to be a major one, but other than that, we really don't do anything as far as interventions. With those skeletal injuries that are listed out up here, clavicle injuries are really prominent, especially if you have those macrosomic babies. So if you would notice that the baby's not moving one arm over the other, or becomes real fussy when you move one of those arms, those are going to be things that are going to alert you that there might be some type of trauma. So immobilization and making the healthcare provider aware of what's going on. So getting x-rays and those types of things done are going to be very important. I will continue on with this brachial plexus injury on the next presentation.